Hi, welcome back. We now have Katie, council with us to walk us through the Senate proposal of amendment 816. And this is on up for action today, correct? Okay. All right. Fast and furious.
Good morning, Katie McLean, Office of Legislative Counsel. There we go. So what I have is this 816 3.1. This is the report of the Committee on Senate Health and Welfare. Their changes are highlighted in this draft, so I thought that would be helpful for you to sort of see the differences. I guess this is an imperfect tool because it doesn't show what has been struck through. So it shows that the language that they have added, but not the language that they have removed. But it gives you a sense of where some of the changes were. So for the purpose, it is the purpose of this act to safeguard individuals seeking mental health services in Vermont from psychological harm, including death by suicide, by ensuring that these services are delivered by mental health professionals and not independently by artificial intelligence systems.
That's new language, right?
If it's highlighted,
Okay,
that's
yeah.
new language.
Okay.
It wasn't in the House version. Section 2 on professional conduct has for any mental health professional engaging in the prohibited use of artificial intelligence pursuant to the next section. So this language is meant to pick up this language, the title of this section. And so this applies to OPR professions, mental health professions. And you'll see a new section that is very similar language that applies to Board of Medical Practice mental health professionals, or who is listed as a mental health professional in this definition, who's governed by Board of Medical Practice. In terms of artificial intelligence, there's no longer language about generative artificial intelligence. Same definition of mental health professional. Mental health services has changed. Means counseling, therapy, or psychotherapy services used to diagnose or treat an individual's mental or behavioral health, or provide ongoing recovery support, including providing therapeutic decisions, issuing direct therapeutic communications, generating treatment plans or recommendations, or detecting or interpreting emotion or mental states. Therapeutic communication means a written, verbal, or nonverbal interaction intended to diagnose or treat any type of mental or behavioral health concern, provide ongoing recovery support, or provide any advice related to diagnosis, treatment, or recovery, such as engaging in direct interactions with clients or patients for the purpose of understanding or reflecting the client's or patient's thoughts, providing guidance, therapeutic strategies, or interventions designed to achieve mental health outcomes, offering emotional support, reassurance, or empathy in response to emotional or psychological distress, collaborating with a patient or client to develop or modify treatment plans or therapeutic goals. And the top of page 4, delivering feedback intended to promote growth or address mental health outcomes. Subdivision 5, therapeutic decision is the same. And then this subsection B and subsection D sort of compress a lot of the work that your bill did, but it removes some of the nuances around exceptions for supplementary administrative tools and administrative tools. What is the, I forget the term that you used. You had administrative and supplementary resources, and those were exempt. And this does the same work without having quite as much prescription around it. So this language in subsection B, an individual, corporation, or other entity shall not offer or provide mental health services through artificial intelligence without the review and approval of a mental health professional. And then there's language that a violation of this section by a corporation, an entity, or an individual who is not licensed, certified, or rostered as a mental health professional shall be subject to the Consumer Protection Act, and that each violation shall carry a civil penalty of $10,000.
Can I interrupt? Individual is still in, and I'm
So this
confused.
is the report of the Senate Health and Welfare Committee. And this does not reflect what happened on the floor. So that was the next thing I was going to say, is that there was a floor amendment to remove individual in subsection B and C. So this, you do not have a document. I don't have a marked up document of has passed the Senate. I only have a marked up document of what happened in Senate Health and Welfare. So that's what you're looking at. So it's not capturing strike throughs of that committee, and it's not capturing what happened on the floor. Or there was an amendment in B for B and C. B is slightly rewritten, and C, in both places, it removes individual. So they would only apply to corporations and entities. So that's the change that I think you're referring to.
Mhm.
And then in subsection D, this is new. Nothing in this section shall preclude a mental health professional who is operating within the professional scope of practice, from utilizing AI tools that are compliant with HIPAA and provided that the mental health professional reviews and approves any mental health services. Section 4, this is the section I referenced before, about having parallel language with regard to the Board of Medical Practice. And section 5 is the creation of a new report from OPR to come back next January, OPR and Board of Medical Practice, to submit recommendations to various policy committees for the regulation of the use of AI by regulated professionals, including recommendations for legislative action. The genesis of this was that there is some conversation from OPR that I don't want to say why limit it to mental health professionals, but that there could be a wider look at the use of AI in many of the professions that OPR administers. So Senate Health and Welfare took that idea and asked for this report. And then you have an effective date on passage.
So I have no idea what happened. What effectively sort of, what did this language do to this bill?
It's more streamlined. There are fewer sort of nuances in the language in section 3, but ultimately it has the same goals and effect of requiring a mental health professional who uses an AI tool to review and know what they're using, review and accept what the AI output is before using that with a client. And it also has language that says a corporation or entity cannot issue mental health services using AI unless it's with the review and approval of a mental health professional.
Like, would that inhibit my ability to go to ChatGPT and say, how am I going to get through this next week in the legislature? What do you suggest? And not be able to actually respond to that?
That's you as an individual as opposed to the provider. That's different, right? If I'm understanding you.
I'm just, one second, I'm trying to find the language in the amendment. I don't have the property in place. Let's see. Here, let me stop sharing and let me pull up the new language. I think that might be helpful. Okay, so this is what ended up passing for that subsection B. So subsection B was withdrawn and or struck in its entirety, inserting in lieu thereof a new subsection B. You'll see it doesn't apply to individuals. A corporation or entity shall not provide, advertise, or otherwise offer mental health services, including through the use of AI, to the public unless the mental health services are provided by a mental health professional. So this is prohibiting a corporation, a chat box from providing, advertising, or offering mental health services to the public if it's not a mental health professional that's offering them. So this would allow HIPAA, as we see in subsection D, if there's a HIPAA compliant tool that a mental health professional is using, a HIPAA compliant AI tool that a mental health professional is using, that mental health professional uses the tool, they review the output before using it. That doesn't prohibit the mental health professional from using that tool. But what this subsection B is saying is that to the extent there is a chat box or a corporation that owns a chat box, they can't provide mental health services as defined in the bill using AI to a member of the public if that service isn't being provided by a mental health professional, which a chat box would not be.
Can you go to the definition of mental health services, Katie?
Yeah, I have to switch down.
Because I just want to flag for everybody that this definition is what came back from the Senate, right? Did they change it, Katie?
Of mental health professionals?
No, mental health services.
Yes.
I think they did, but Maine has just passed a similar law that uses a different, more narrow or more broad. It's a shorter definition. And it's been recommended that we consider that in order to stay regionally aligned with what people are doing in this space. This is not the main definition.
No, this is what came back from the Senate. So it came back from the Senate, again, counseling, therapy, psychotherapy services used to diagnose or treat an individual's mental or behavioral health or provide ongoing recovery support, including providing therapeutic decisions, issuing direct therapeutic communications, generating treatment plans or recommendations, or detecting or interpreting emotion or mental states. And then what passed in Maine. Wait a second. I'm not sharing my inbox. Is that mental health services means services provided to diagnose, treat, or address an individual's mental health or behavioral health through therapeutic communication. Right off the top, that excludes therapeutic decisions. So, I mean, that's a policy decision for you, but it would seem that you have a specific definition of what therapeutic decision is, and you would probably want to say that also. Right now, therapeutic decisions and therapeutic communications are listed as including in mental health services. And this change is that the diagnosis, treatment of an individual's mental health or behavioral health is through therapeutic communication or through a therapeutic decision.
I just have questions about it. Can you go back to the part that said, that defined mental health services?
Yes. Yes, as passed Senate.
Yeah, the most recent version. I'm wondering, like, is this the only place in state law that's going to have a definition for mental health services, or is it defined in other places already?
I don't know if there's a specific definition of mental health
So
services.
this would be the first time we actually define it in the,
Oh, I'm not saying that.
Okay.
I don't know. I have to look.
oh, okay.
Yeah. There's probably variations, but I don't know if the exact term mental health services is defined.
I'm curious about that, because if we're talking about being consistent with Maine, we should also look at being consistent within our own law. And then The second thing would be, I'm just concerned about detecting or interpreting emotion or mental states. Every human does that. That's like part of our basic functioning as humans. We're detecting and interpreting people's emotions and mental states. So to now define that as a mental health service, like if an AI is trying to do that, to communicate with a person better and to respond to them better, I don't see that as mental health services. I think if it's being used, if it's doing that to then go further, then it's a mental health service. But I think the simple act of detecting and interpreting emotional state, I would be hesitant to start defining that as as a
No,
service.
but it was with intent, right, Katie?
It's prohibiting it.
No, it's with use to diagnose or treat. Like, we were trying to isolate it, but so see, there's some complications around, I think, the definition of mental health
Okay.
services with regard to like our original intent of wanting to be able to allow the use of digital therapeutics by our professionals, make sure that they feel empowered and safe to do that. But also minimizing harm to patients. So Brian, I think we're on the same page that there are some nuances that we want to be sure we address.
Yeah,
I think we can discuss this more, but I'm just going to be frank with everybody. I think we need to discuss it a lot more than we have time to do today before it comes up on the floor.
Maine's definition is much more broad. It just defines mental health services, means outpatient counseling, other psychological, psychiatric, diagnostic, or therapeutic services, and other allied services. That's
That's not the definition that I was sent, so I'm curious where, yeah, but where are you reading that from?
from the Maine statute,
2082?
either later on. 3202.
That's not the right one. It's LG
3601.
so Maine has different definitions of mental health services in their law, it seems.
Probably do.
There was one other question or comment I had. Just that the way that I agree with what you just said, though. I wanted to say that I think we need to explore this more. And what I see ChatGPT doing when I ask it, I would say wellness questions, is finding wellness information for me. And it has done interesting things, like on its own said, would you like me to take these 5 interventions you're researching and combine them into a recommended regimen? And I'm like, okay, but I don't trust you, you know? So I feel like that might be where it's crossing the line a little bit, but I don't think that this would inhibit people from using AI to gain access to resources. It would just put a limit on how far that AI goes with making recommendations. And I have found that it's behaved in questionable ways when I'm experimenting with it. So I do think we need to be thinking about that, because there's a fine line between what's self-help and what's formal treatment from a licensed provider. I'll just leave it at that.
Yeah, and I think Katie did an incredible job around the therapeutic communication definition. And I worked with an ASW to pull in a little bit more language from what the Senate did, just to specify that what we're really talking about is clinical advice, diagnosis, clinical treatment, and make sure that we're really focusing on like the clinical setting here, because I don't want to prohibit people from having access to those low barrier supports.
Am I reading this wrong? I mean, I'm just seeing this language for the first time. I mean, essentially the bill as passed by the House, it felt like we were trying to ensure that licensed professionals that we have in Vermont providing services to Vermonters, that we were that AI as a tool can be used. However, everything has to have clinical decision-making ultimately by the licensed provider. And am I reading this in that it's sort of expanded it now to everything?
Katie?
I don't know what everything.
Well, that any mental health services, regardless of if they're provided by a licensed professional, which seems like it could be anything.
It says that a corporation or entity shall not provide those services using AI.
And then
Which-
they expanded the mental health services definition to include things like empathy is in there somewhere, or interpreting empathy.
Detecting or interpreting emotion and
That's
mental
the part I
states.
was concerned about.
Yeah, so, for example, when I'm on a job board and I'm saying like, I've been unemployed for this long and it's really depressing. If the job board says like, we understand, that's why we're here to give you this list of jobs. So we understand, like, we don't want to penalize anybody for saying something like that, right? Like, that's not who we're targeting. And we want to allow people to continue to develop other tools. And we want to focus this on tools that enable clinicians to do their work and clarify for them what they can and can't do. And since that is in OPR's lane, I had a chat with OPR. They also testified in the Senate. They want to be added to the AI Advisory Council that we talked about when we worked on 814. And so I think there's an opportunity to have them build upon any recommendations that might come up in terms of clarification to help clinicians or to help let some of these technology companies know exactly what we do and don't need. So there's that space in that advisory council. And I'm recommending adding that section 5.
Go ahead, Brian, but let me put something out there first. As it came over from the Senate, I am not prepared to support the amended Senate version. Where that goes, so I would like to ask for at least a delay on this, because it is up for action today. And I think we need to either take more testimony on this. And then we can discuss whether or not we want a further proposal of amendment or possibly ask for a committee of conference. Those are my feelings right now.
Just
And
thinking about calendar math.
I
I know we can't deal with it today because we
Yeah.
can't, but I think we have to think about if we're done next Friday.
Yeah,
Yeah,
I'm
I'll
just,
be thinking about it.
yeah, and I'm just thinking, just on this first read, for myself personally, I'm not comfortable, like, recommending that we concur, and I'm recommending that we at least try to get some testimony tomorrow on this, and then decide what to do with it. Is everybody okay with that? Okay,
Thank you so much,
let's
Katie.
do that. And did you still want to ask your question?
Yeah,
That, I want
or make it, yeah.
I have an answer to your other question.
Which
So,
one? I know.
Definition of mental health services. So there is at least one other definition of mental health services, specifically in the health insurance title. I don't know that it is useful for our purposes, and we define the same term different ways in different contexts. So that is an overlay. It means acts of diagnosis, treatment, evaluation, or advice for any other acts permissible under the healthcare laws of Vermont, whether performed in an outpatient or institutional setting, and include treatment for substance use disorder.
Okay, thank you.
Mhm.
We are gonna come back to this, so I don't want to belabor the point, but I wanted to just make this point, because I heard other members bring up the detecting language. One concern I have about leaving that in is that, and I don't know if this is a question that you can answer, but like would it then prohibit artificial intelligence technology from catching a problem and calling for help or sending someone for help? Like if someone is trying to use ChatGPT to plan their death, and which has happened, that's part of what's driving this effort, and ChatGPT can't detect that that person's depressed or asking or suicidal, then how would ChatGPT know to say to them, call this hotline, which is what it does now. Like I ask questions about Ibogaine and it's like, call this number if you have drug addiction, call this number. This is not medical advice. Like that stuff pops up. And I'm just asking it like, what's the range of a booster dose of Ibogaine, and then it starts saying that. So like it's already detecting like questions about drugs and mental health and responding in a way to say to you, I can't give you medical advice, call your doctor, or if you have a problem, call 9188 or whatever. If we prohibit it from being able to identify if someone's suicidal or depressed or anxious, then we might actually contribute to deaths because it won't catch them. So I think that in order to prevent harm, it has to have, I don't think we should prohibit its ability to detect emotions and mental state. I think that's different than it, because it's not invasive. You're giving it to it. You're like telling it how you feel. So it's not like it's going in your head like the neural data. So I don't know. I made my point. I don't need to belabor anything I said, but I need to say, we can talk about it later, but I just wanted to get that out now so that it's out there.
Yeah, I agree with you,
Okay.
Ryan.
Okay,
The issue did come up, the same issue came up in Senate Health and Welfare. We talked a little bit about how you're right, it's viewpoint neutral. So it's not allowing some statements by AI, but not other types of statements. And some of the conversation there was, how do you control whether you think AI is providing a response that's aligned with clinical practice versus whether it's providing a response that isn't aligned with clinical practice. So that was the conversation downstairs.
okay. Well, I think we should table it for today. So we will, form the clerk's office that will be acting largely. Okay, great. Thank you. Thanks, Katie.
Thank you so much, Katie.
All right, so back to 197. Is Jen back? Oh. So I had on the schedule, I wanted to talk about section 5 and sort of get the thoughts from the 4 entities named in section 5. And I think I'm gonna flip the schedule a little bit and I'm gonna start with the healthcare advocate. So Chief Fisher, if you would like to join.
I don't know what to call me. Hi, I'm Mike Fisher, the healthcare advocate. Yeah, I thought that maybe I can just attempt to set the stage a little bit. I think I recognize that all year long, this committee has heard from the different entities about what they say they're doing well and what they think is missing, and what and maybe in cases what they concerns about what's not being done. And I know that the members at this table also have similar discussions and concerns about the landscape. And so as I read this language, I think it is intended to tee up a conversation for next year. Sort of, how do you sort of bring to the table a start of the conversation from the various entities? And so I think that's not a bad idea. But I think that I've been around this long enough that my caution is that I wouldn't want to ask for consensus or consensus building at this stage. I think I would want to
Sorry.
I think I would want to ask the entities to consider the gaps and areas for improvement, and maybe on a little bit of a higher level, not name every detail, but and ask them to come with a recommendation in January, and that maybe that in and of itself would facilitate and if there's opportunities for the entities to come together and work together to figure out stuff, they can do that. But I wouldn't want to ask them to spend a lot of time being in the same room. I think they can do that on their own. I just I'm not sure I see as much fruitfulness in that. So, and as far as the HCA, if indeed you go the direction I just said, then I'm not sure that the HCA needs to be, at the table if there isn't a table. Though we would be to the same end, we would be happy to give our thoughts as well.
I realized in here, it's just asking like for sort of a report back. And do you think that if they do engage in, discussions, that rather than a single consensus report back, and I use the word report really loosely here, could be a letter.
That
You think that
they report.
that the individual entities should report back their own,
I do.
Yeah.
I actually,
opposed to one cumulative.
with the caveat that I recognize that the administration, the DFR and AHS are part of the same administration. So there's a sort of structural difference there between that. So I mean, they can talk about how they would facilitate that, but they are part of one structure. So yes, I think asking the entities to report their recommendations to the legislature, maybe when you call them in January.
Thank you.
Maybe I could.
Oh, I'm
So
sorry.
are you seeing three entities? You're seeing sort of the administration with those two, and then the Green Mountain Care Board is another, and then you. So is that what you're thinking?
I think that makes sense.
Okay.
Let me just say again, I would ask AHS and DFR to consider what makes sense for them. I don't want to speak for how they should be
Right,
organized.
right.
That's their job.
That would be one, and then two is Green Mountain Care Board.
Yeah.
And then you. So there is no consensus, and that's what you were talking about. Everyone gets their own opinion about. And the question that's being asked, is that clear? Do we understand what we're asking them to respond to in this section?
I think it is making sure that everyone's, there's clarity in roles. And I do think it is gaps, areas where there are gaps and where there needs to be improvements. I think
And specific to transformation, or specific to more than that, or what?
I think you've heard significantly more than that.
Yeah. So beyond transformation, beyond the entire
Yeah.
focused on, since this bill is about universal primary care, is it about that? Is it about implementation of that? Not necessarily. So what, so I'm just trying to get the.
I think it is about our healthcare regulatory planning. All of the activities of state government and
So all within the healthcare space?
Yeah.
Okay. That's pretty big.
Yeah. If you're asking, I'm trying to be responsive to what I've heard from various other people. I'm not necessarily saying that I think there needs to be a rethinking of all that stuff. You won't hear from the HCA that there needs to be a broad change in all that stuff.
Right.
But I think you've heard perspective, and so give the entities an opportunity to make their case.
But we were hoping, if I understand sort of the origin of this, was that we wanted things to be moving a little quicker, asking them to respond in a timeframe kind of way, or not necessarily.
I think
Get my head around.
I think my concern is, and why I proposed it in this, is that if our intention is to, as a state, move forward with universal primary care and developing universal primary care, there will be key decisions along the way of how and who will implement. And it will involve various entities. And I think that as we make decisions over, who is best tasked with achieving those goals, it's important for us to ensure that we've got all the information on who is best positioned to do that, and where maybe alignment could be had to allow us to further implement things.
So if, sorry.
No, I mean, we've in this room have made decisions. We sort of make decisions like that all the time. Well, who's best to do this? Should it be the board? Should it be AHS? I mean, and we make the best decisions with the information we have, but sometimes those decisions have led to unintended consequences for another entity. I mean, a perfect example is the Green Mountain Care Board is responsible for rate setting for QHP market, and yet we also have DFR who is regulating the entities, and are they aligned? And I mean, I think that you would find, and not bad or good, I'm not making a judgment call, that sometimes if people have a different charge, if DFR's charge is insurance solvency and protecting the insurance market, and the Green Mountain Care Board's charge is, for Vermonters and the costs, are those working in alignment with each other?
So I'm just sort of thinking here. So let's say we want to implement universal primary care by 2030. What structures need to be in place in each of these entities in order to accomplish that? That kind of question?
Yeah, or which entities are best positioned to be able to implement that? And which decisions we make in the various entities that it goes to, are there possibilities that we could have competing interests? And which doesn't allow for smooth implementation or planning or, I mean, I'll give the example of hospital transformation. We have the Green Mountain Care Board tasked, and they're working right now on reference-based pricing. How are they going to set the reference if they aren't party to hospital transformation? What are they referencing to if they don't know where we're going? And that's what I'm sort of talking about, is everybody able to actually function at their highest level, or are people working in silos where they're not given the information or not a party to the information that needs to they need to have in order to make other decisions? I think that's all. And then I'm going to let Mike.
Well, I'm ready to go. My questions weren't for you.
Well, let's have Mike, and then you can.
Here
I
we go. Sorry.
read this language to be significantly broader. This is about our healthcare regulatory structure. And, I know it's in the context of 197, a primary care focused bill, but the language to me is not about how do we set our regulatory structure up to achieve universal primary care? If that's what you want it to be,
No,
Okay.
well, it's in this bill. so
Yeah,
I think
it does
it's
say
confu- That's part of the confusion.
I want a level set. So when we do start making decisions,
Mhm.
that we, as the legislature, will have better information on who should be implementing what, where, when, how, that sort of thing.
Okay.
And so this is looking at the current structure that we have now to see where there's areas of agreement, where there might be areas of conflict. And so that we have better information going forward with where to house things. That's what I'm. This is not, section 5 is not who should implement universal primary care.
Right, and I think that's confusing. Well, I thought it was focused a bit on that, so that's helpful. Thank you. And I'm hearing you say areas of agreement, areas of conflict. And I'm trying to think about charge in order to have people focus on the questions that we want. So in a way, you're saying what the questions are in order to do what? In order to optimize the functioning of our healthcare system, in order to,
I have a list here.
where are you?
On page 10, line 7, it says, in order to optimize collaboration, information sharing, and efficient operations in furtherance of attaining the principles for healthcare reform set forth in, I'll just say Act 48, and as codified at 18 VSA 9371, establishing universal primary care, improving access to high quality, affordable health care services, accomplishing healthcare transformation, and safeguarding hospital sustainability and insurance.
That works.
Sure, solvency. It's quite exhaustive list, yeah.
That's their charge.
Well, then maybe we should make it higher in the section, that's all. Just be clear on that's what we want. Because it felt buried to me. And it took me a while, it took me till now. I mean, I read it, but it's broad, and I think that's very helpful, but I think we should put it at the top. But that's okay.
So if we're looking to get positions from the various entities on how to move forward, shouldn't we have the chief prevention officer involved in this? Because the role of that position is identify and coordinate initiatives across state government and among community stakeholder groups that improve well-being. So that's the chief prevention officer's role, is to get these various entities, Green Mountain Care Board, AHS, DFR, to work together to see how they can operate.
I have to be honest with you, I don't know what the chief prevention, where is that?
It's out of the administration, and
It's
It's in the agency of administration, right?
Oh, that's wrong.
Yeah.
yeah. And it just seems that that would be the perfect role to get these three entities together to form the thing we're looking for.
I think it's a great question. Let's ask AHS and the board and DFR when they come up, what they think about that.
All right.
I didn't know that was the title. Thank you. Let's see, Jill.
You. Good, what is it? Good morning, everyone. Where am I? Jill Olson. I am the Dedicated Health Systems Director for the Agency of Human Services. I will talk about Section 5, but Madam Chair, I did have those other concerns that we've talked about around some other changes yesterday. Is that okay if I address those too? Okay,
let's
I'll start with Section 5. Okay. I'm just gonna try to get the bill open. As my computer does nothing. Hard copy. Just frozen. I'm gonna just start talking and see if it'll, I don't know, wake up. You want to look at a hard copy when you're talking? Oh, do you mind?
Not at
You're
all.
so generous. I marked mine up here. I can't get my printer to work at home, and this was a late night thing. Okay, let's
I
focus.
get to them within 10 minutes.
I can do it.
because Ledge Council actually needs to go.
Fair enough. Okay. So I would say that on balance, we are supportive of this concept. It's something we've talked about behind the scenes a little bit. I think that you have observed some of the questions about role clarity that come up. Emily and I, we've all talked about it. And so I do think that you're identifying something that is a real thing where there's some room for discussion. I think we can generally, support moving forward with some version of this. I definitely don't want to write a report. So I think we're talking about something more informal than that. So I just want to say that out loud. And I would actually be less specific than you've been, not more. Only because I don't want us to all have to spend a lot of time on things where we actually might not think, and it might be possible that none of us think a change needs to be made. And so now we have to sort of wrestle with, a particular item that you've listed. So I would probably recommend leaving it more high level so that we could talk about recommendations for change, so that everything else that none of us think should be changed is the default. So that would just be a suggestion to simplify it a little bit.
Can you tell me where you?
I would take out, so the words that you listed that you liked, I'm saying I would cross those out. So I'm on, I would say, no, let's see, page 10, line. Wherever it said the blueprint, I'm trying to find it. This is why I had my
Line
highlighted
4,
copy.
2, 3, 4, 5.
Yeah.
Transformation, all that. Yep. Line 2, 3, 4 in there. I would actually leave it more high level where we would evaluate our roles respective in healthcare regulation, healthcare reform, and not actual list items. That would be my suggestion.
I don't want to interrupt, but I think that I did not clarify correctly. So I know you had changes in other parts of the bill. So let's start with those on Ledge Council, not section 5. We'll come back to section.
Oh, I'm sorry. I heard you.
I know. I think I was not clear.
Or I didn't listen well. Both are possible. Okay. So thank you for the opportunity to talk about some of the other sections of the bill. So and this is why I want my copy, because this is really a little confusing. So you made a change yesterday that I think you thought was more just a kind of moving stuff around. And what you actually did was change who's doing it and also by when.
Is this the blueprint targets? Yeah.
Yeah. Okay. So
6.
thank you. 6. So, but the move you made moves it under blueprint. It's really a diva task and changes the date from 2028 back to 2027, just because of where it's moved into a section where there was a different date. So those are both things that matter to us. I mean, the Agency of Human Services, I think, is who was assigned, but it would typically be DIVA, not the blueprint. So I would prefer to leave it Agency of Human Services. I guess I like it the way it was. And I would prefer that matter to us in terms of just the capacity of that group. Then that is in fact the group that is also now managing this new request that we have from CMS on provider revalidation. It's part of this fraud, waste, and abuse focus. So I really want to make sure we're not adding new tasks outside of the timeframe that team identified as the one that made sense.
Change the date to what?
Back to 2028. So,
Yeah,
please.
Jen Carvin, the City Council, can I just clarify, because I think part of what they did yesterday was take that AHS out of statute. Are you okay with it being just the standalone, what was formerly section 5, primary care spending targets report, and some version of that's a 2028 report, but not tied to codifying the targets and directing spending there?
Jen, say it again. So am I okay with restoring section 5 as it was?
Section 5, not
The statute?
Section 7 and 10 that was being added on the top of page 6. So adding back the language that was section 5 on page 9, but not adding back the language that's struck on the top of page 6. As long as the concepts, may require more explanation.
So I'm not sure.
Okay.
I feel like I need to, but that's a yes, no question. So I just need a little
Okay, I'm
more.
happy to get offline.
Yeah, that would be great. Okay, but I agree with you. Those things typically would, were built to go together, and so that is a great question.
Okay.
Yep.
Nice catch for whoever caught it.
Jill Wilson got it.
Oh.
Got it all by herself. Yep, about 5 o'clock, and then I had a little panic attack because I hadn't caught it before. Okay. And then I did talk to the Blooper team about some of the the language on page 7, establishing a target for PMPM, transitional schedule. Oh, that's what was there. No, it's the you added some new blueprint language on page 8, line 6. Description of the ways in which Blueprint can optimize delivery of services within the current initiatives. So if what you mean is to describe the new payment model for CHT that we're working on, that's fine. We can do that. So I think that's what those words mean. And the team felt that they could do that. And then I would finally ask that you added a new task for us, section 8, to do this sort of survey of different states on universal primary care, and I would prefer that that not be assigned to AHS.
Oh, Brian, go ahead.
Do you have any recommendations about what the best approach might be to doing that work? Like, might it be best done by a working group or like some other branch of government or existing body?
I don't. If you really want to really dig into primary care at times, this body has actually hired their own consultants to do work. You have done that. Obviously, that changes, the fiscal note implications of the bill, but that is something that this body has done at other times in healthcare reform.
Can you give an example?
Back in the single payer days, that there were a couple of studies.
You're talking about like the 2011 study or whatever it was.
Yes, exactly that. But I'm just saying it's a thing that sometimes the legislature has done. I don't have a recommendation for which entity of government would do a full study of universal primary care.
But you're saying not us?
I'm saying that.
Okay, thank you.
So do we, at a full scale study of universal primary care implementation needs to be done? I mean, is that what this?
No, it's been done. It's been
It's
done.
been done. That was in 2018,
16.
16, whatever.
There's been many a study.
I pulled it.
feel, and who wants another study, and I get it. But they're not mentioned, those studies are not really mentioned in this bill.
It's kind of a survey of lots of other states' work. I have no idea what other states have done. I don't know how extensive this would be, but it's a fair amount, it's a lift to go and look. Because I doubt there's a list out, maybe there's a list, but if there is, then you could just pull that, so. But I don't think this is a task I want to ask the team to take on.
Might just pull up Nashville.
Yeah, just let's ask them.
Yeah, right. Yeah, so that would be, your legislative association. I mean, there might just be other bodies who might be able to pull this information for you.
Okay,
So that's
talk about 5 more, or
I think I said essentially my piece. So we're comfortable conceptually. I do, I hope that we would be able to actually identify consensus to the extent possible, but I realize we might not be able to. Just again, to say my primary point, I would make it less specific. So that we can focus on the areas where we think there should be change instead of having to focus on areas where we don't think there should be change. That would just narrow the scope of the work for each body, each of the groups. And if we wanted to collaborate, if one felt like there needed to be a change and another didn't, that will come up in that process. And I think that'll be useful information for you. I would also add that as part of the development of the strategic plan that's due in 2028, we have been inventorying from every department within AHS, and also who's now done the Green Mountain Care Board, and we haven't yet done DFR, but we will, just everybody's role in the healthcare regulation and reform space. It's just something we've been working on as a thing that we felt like we needed in that, partly because, and I think this is what you grappled with this year, it's a little hard to understand like who does which parts. And so we felt like actually part of the strategic plan that would be a helpful thing for us to consider, and so that it might be more clear. So this has been on our minds.
I see, Leslie, you have a question, but do you want to weigh in on Dave's,
Yes,
um,
the chief perfect,
You know, I sort of feel like I'd like to ask the chief prevention officer how she feels about it before I weigh in on her behalf. Yeah, so, but I would also say, just thinking structurally, that's a person who works for the administration. And so I would expect that our position, DFR and the Agency of Human Services, we would come together. So it's not really a neutral party with the Green Mountain Care Board. So I would just acknowledge that.
Isn't the role though to get the three entities to provide their positions and then to get them all together?
I'm just saying the Green Mountain Care Board is not part of the administration. And so if I were them, I would feel like that was not an entirely neutral facilitator.
and if the administration would get somebody, then maybe the legislature should have somebody as well. And now we've got a
And if you
whole
give them loose up, then yeah, it starts to be a lot of people.
kind of room big enough.
Yeah.
Yeah.
I think, I agree, this could be hard. I don't disagree. I mean, we had some challenges this year as we tried to work through F 189 in terms of who was going to do what. So no question, there's conflict potentially to be had. That's, what we do. And I actually think the Green Mountain Care Board staff and the HS staff have actually been working together incredibly productively over the last several months. And I feel really good about that work. So, I'm hopeful we can make it work.
Leslie,
I just need clarification to understand what you're saying. Well, I think, so
I
are
don't
you
think so.
saying, that you agree that these different entities do their own separate analysis and write a letter? Because you're saying no report. I'm just trying to.
Yeah. So I definitely don't want to do a report. I hadn't thought about the healthcare advocates idea of having everybody do their own and then collaborate as they want to or think they could. I think that's an interesting idea. I mean, it kind of seems, I could see the simplicity, but I also sort of like the idea of having to work together. Like a little bit of it being the forcing function, even if it's hard.
So who would you imagine, being sort of in charge of setting the meetings and the agenda and facilitating? How does that work?
I think we'd have to sort that out. I mean, there isn't an obvious that I have not been able to think of an obvious or fully neutral party that could do that.
Right. And
I mean, we do it now. We have meetings between the Medicare board and healthcare reform staff. We do it every week.
yeah, who sets the agenda then? How does that work?
Actually, the way it works is a member of the Green Mountain Care Board team very graciously volunteered to be hey, what do you guys think? Here's what I have on my list. And the rest of us say, yep, that sounds great. How about this too? And we just kind of work together. It's pretty informal.
And who
But
runs the meeting?
Emily and I, kind of depends on the topic.
You guys. Okay, so
Yeah.
as far as section 5, you're okay with that sort of less defined, and I know you're gonna come up and sort of sounds like this sort of less defined model is something that you see as workable, and you see yourself coming out with a joint letter by January, whatever it is, somewhere in 15th of 2027.
So I don't know that we can come to consensus. I'm not sure how much disagreement there is. So that is something we'll have to explore. But it's certainly possible to write a letter saying this is what,
We
everybody
agree with,
thinks.
this is what we don't agree
Yeah.
with, that kind of thing.
Yeah.
I
Or
think
even just to do a recommendation, to do a test.
of each party having their own is so that you don't spend 10 meetings trying to come to consensus on what's going to go in the letter.
Yeah.
So everybody write their own report, which is not a report. So
Please stop saying that word.
Your own.
Yeah. Recommendation.
how do we say a recommendation or a
What
report?
does it
back?
say? Yeah, a report, yeah.
A letter. Yeah, a report back. Okay. Any other questions for Director Olson? Okay. Thank you.
Great, thank you so much. Thank you so much. Sorry about that.
Thank you.
Sometimes the paper works better than the machines. The problem is I can't get my printer to talk to this machine.
Yes.
Hmm.
No,
For the record, the Orlando Joint Fiscal Office, while the legislature has done study in the past, they had Dr. Shao did a study there was a high level study. In the end, the administration did all the work, did their own studies, and wound up actually doing something much different than Xiao had proposed. So before you start deciding if the legislature should do it, or JFO or Ledge Council, we need to compare what was done and what we can and cannot do. So before this committee makes a decision about what JFO or legislator should do, let's have a further conversation.
Go ahead, Brian.
I know that we're allegedly ending next Friday, but I'm wondering if there was time, because there may not be, if it might be useful before we make a decision on that section about looking at, the part AHS doesn't feel like they should do, that before we decide, maybe having Nolan or another witness or a combination of witnesses quickly, like it doesn't have to be super detailed, but kind of quickly review for the committee all the things that we've done. Like what you just shared was like an example of like the nuance and details of what we did at that time. It would be good to be like, let's rewind to 2011. What happened in what order? Why did things get derailed? What have we studied since? Because it might be good to not make the same mistakes, or there might be something that worked that we're like, that actually worked. Why don't we do that part again? So I don't know. It might only take an hour to thoroughly do that, even though time is short. So I just was wondering if that might be something we would consider before we decide.
I think we'll have time for like testimony. I know that would mean that you would have to do a whole history of.
Dig deep in the
You-
catacombs.
So that would be work for, I know that would be a lot of
Think about
work
a way
for
to
you.
get to that. I understand, I can probably do a higher level, but to get you someplace. And I also want to remind people, there was actually another study before the Dr. Shao study, the Ken Thorpe study. Yeah.
We are old.
That's a deep cut right there.
You can go back to 1791. I'm fine with whatever.
I think the Raptina's request, I think it is doable for me to go back and say, we did these things, and that the administration, at a high level, I think I can do that.
And links are.
Like who did what? Because it might be like, who did this? Who did that? Because then we're like,
Yeah.
who did what? Do we want to do that again or not?
I just want to say that I see section 5, the new section 5, as being detached from this conversation. This is more, okay, so when we do get to that place next year and we're having to make those decisions, that we have like sort of and then we can go into the nitty-gritty of, let's see what's happened in the past, and we'll be able to make better decisions on where to go forward. Let's have Emily Brown come up. Sorry, I'm trying to use people's titles now. Director?
Yeah, sure.
Director Bradford.
Thank you.
Just agrees.
Yeah, I like that idea too. Good morning, I think. Emily Brown. I'm the executive director at the Green Mountain Care Board. I think the Green Mountain Care Board, or I know the Green Mountain Care Board supports section 5 as a concept. I agree with the healthcare advocates' suggestion of making sure that each entity who's included in the study has an opportunity to kind of come forward with its best and, ideas and thoughts. I kind of view this exercise as, all of our agencies and entities have really smart, dedicated public servants. And so while we may not always agree on what the solutions are to issues or how regulatory functions should be carried out, I think I'm viewing this as an opportunity to kind of bring those all to the table next year so that we can have an informed discussion, or you all can have an informed discussion around all the points that we're kind of bringing to you and all the ideas. So I support this concept. I think that to Jill's point, there might be areas where we have consensus and there might be areas where we don't. And I think, as she said, we work together on a weekly or bi-weekly basis. So we have existing touch points. And I expect if we were to engage in this work, we would be openly communicating with AHS and DFR as we move through this. And again, I don't think you should require consensus. I don't think that would happen on all points. But I think, making sure that there is, an expectation of communication between the agencies makes sense to me. So I will also say I like the idea of pointing out areas which you'd like us to focus on. Clarity's kindness. So like when you can, if you want us to address something, I think it's important to lay those out. And you've done so here. And then to the question about the chief prevention officer, I would agree with Jill Olson's point. I think that is a position that's embedded in the administration, so wouldn't necessarily be someone who I think the Green Mountain Care Board, might have alignment, might not at some point. So I don't really have a comment on that being part of the DFRHS process. I think that might make sense for them, but I wouldn't want to speak for her either. So so that's all in section 5. And then I did want to bring up, I think Elena Barabee, our director of policy, was in here, I think it was April 1st, to talk about a prior report that we had done, the Green Mountain Care Board had done. And I want to draw your attention to section 6, which is requiring us to update the 2017 clinician landscape study. I believe when we did that report prior in 2017, we had a full-time position, as well as it took us about 18 months. So I just want to highlight some resource concerns the board has for that requirement in section 6.
So we haven't really touched section 6 from the Senate. Was this?
I believe we brought up,
in the Senate?
I believe we brought up resource concerns when we testified on this in the Senate. And again, it might have been Elena Barabee, our director of policy, but we did resource concerns.
Right. We need to think about that.
Yep, just wanted to raise it since I had the opportunity.
Anything else?
No, that's it. Thank you for having me in.
Did you want to, I know that you're not named in it, but section 8, which is bringing fair efforts in other states. And AHS is advising that they don't want to do them. Is this something that Green Mountain Care Board would like to?
I don't have an answer. I wasn't prepared.
Okay.
I haven't, no, it's okay. I would like to go back and talk to my staff and the chair.
Yeah, I have a related question that I was going to ask you, if you had any recommendations about who might be the best party or parties to do that work. So that could include the Green Mountain Care Board, but it's sort of a broader question than the chair asked. So my question isn't like, do you think you all should do this? But who do you think might be the best people to do this work? And if that includes you, great. And if you have other ideas, it would also be useful to hear. Not right now, but like after you consult internally,
Yes.
You might be like, oh, none of you thought of this, but there's the Office of Universal Healthcare that exists that we don't utilize.
I can come.
Okay.
I'll try to get back in writing as soon as possible.
Okay.
It could be. It was formed in 1870.
Yeah, exactly. We just never funded it.
Oh, yes. Hi, sorry.
No. I was just wondering about section 3, where you're talking about blueprint payments for practices in primary care. And whether you think that the Green Mountain Care Board should be involved in that conversation. Might it affect hospital rates, or hospital budgets, or that you think a voice there would be important?
So this again is one that I'd like to take back. So I do know I can say that we have provider rate setting authority generally. So this does relate to that, but I wouldn't want to comment on this. I haven't had a chance to.
That's why I'm just bringing it up to.
So I can also
flag
take
it,
this one back
see
as
what you
well.
think.
Yep.
Yeah, thank you.
Any other questions? All right, thank you so much.
Thanks.
Can we get Mary's title? Deputy Commissioner Block.
Good morning still? Yes, morning. Mary Block, Deputy Commissioner of Insurance for DFR. So we also support the idea of collaboration in section 5. Agree that we are likely to have consensus about some things and not consensus about other things. And so it probably makes sense to hear from all of us as to where those differences exist and where that consensus exists as well. We, I think, probably lean more towards AHS's thoughts around being a little bit flexible, because I think there are things that we already have consensus around. And there are things that we already know that we've had conversations about, should this change? And so we're already starting down that path in some ways. We have no issue. I don't think we need the chief prevention officer. I agree with, from Emily's perspective, that the care board, from the care board's perspective, it's probably not a sort of neutral party. I know that we work daily with the chief prevention officer, so it's definitely something that is a part of our world as opposed to the Green Mountain Care Board's world. So it would definitely slant things, I think, in a less neutral and collaborative way. But we would be having those conversations anyway, because we have those conversations generally from an administrative perspective with the chief prevention officer. So yeah, I think we're perfectly comfortable. We were already having conversations about whether things needed to be rearranged, rejiggered, where there's conflict, how we can work better together. And, as the care board's talking to AHS, they're also talking with us regularly, and we're regularly talking with AHS. So I think by default, we sort of have to be talking to each other because we have no choice. But as you can see, we don't always agree. So we are more than happy to have have conversations about how might change to make that easier. I don't think you're with split responsibilities, which I think are almost necessary. I don't think you could put everything that all three of these agencies do in one place. It would be this behemoth that would be impossible. So there's always going to have to be some collaboration, but we've tried things in different ways over the years since 1872 when we started doing things, or whatever it was. So maybe it's time to rethink how we do it again.
Any questions? Go ahead, Brian.
Do you have any suggestions about who might be the best entity or organization or individual or group or community or other being to conduct the Universal Primary Care Efforts in Other States report?
I think I need the same time to go back and have a conversation and figure that out.
Thanks.
Not something I've considered at this point.
I might strike that because in all honesty, I'm on NASB's website right now and I'm on their state tracker and they pretty much have it all anyway.
This team, yeah, so
Yeah, so
There
done.
you go, done.
can we just use the time then to pick stuff off their website and do it?
No, I'm gonna get AI to summarize it all for me.
I bet it could write a bill and a plan in a minute.
Yes.
Just on that subject of consensus, I think that, and now there are areas we already have consensus in.
Mhm.
Isn't it a simple matter, even within the structure of some specificity saying, okay, we have consensus, focus on, is there any downside?
Other than time, no. And since we're all always strapped for time, having the conversation to make sure we're all in consensus and not make assumptions, it's just and memorializing things. So
Well, thank you.
Do you think we're gonna have a conversation about it now? I'm thinking, that section, I'm sorry?
It's still morning.
I know we haven't done that. Oh, it's only 11:20. With section 5. To me, it stands out from the rest of the bill as another initiative, let's say. Something worth doing, it sounds like, from what I'm hearing from people. And I'm wondering, and I know Jen's not here, but just think about an intent section for that to set it up about why we're doing it, and what we hope to gain from it, and what our expectation, and maybe start out with that language that Brian pointed out in the middle, which is great. And how we want to, so if we could just make it a little more, just for clarity about
Why we're doing
the
it.
intention, yeah.
Okay.
Yeah, that's what I'm thinking about, an intent section for that. And how we imagine it being operationalized by the entities. And what the expectations are to them.
Before we have Ledge Council, utilize resources and time and effort on intent language for this, can I just get a general consensus from the committee on whether or not there is general support for section 5 or not? General support, because if we're gonna strike that, I'm not gonna have Jen work on language. Anyone have strong feelings? I guess I'm gonna say, anyone have strong feelings against including it? Okay, so general consensus is that
Or neutral.
or neutral. Okay, so I'm taking neutrality as, and it would feel better if there was intent language of why we're doing it.
When I would see that,
Okay.
I would feel better about it.
Okay. Right.
Is the language at the beginning of the bill not enough intent language?
Well, it's not to that section. I
But
mean,
it-
I think it's a different topic to me.
Then section 5?
Yeah.
Which is the one where the different entities talk about how they coordinate better?
Yeah, but they're coordinating in a universal way. My intent, my interpretation was it was about universal primary care. I misunderstood, I think, for a while, the intent of that.
Well, you read,
Oh, I'm sorry. Oh, I was gonna say the intent language that says to gather information.
yeah, it's so like we have this, the intent and purpose, it says that it's to invest in primary care and to establish a program. It also says it says it's to obtain the information, to develop a framework, including optimizing the blueprint for health. And so I feel like we say our intent there, and then when we ask them to look at these like it says in order to, when you read it, I mean, it cites Act 48, which was the universal healthcare law, and the foundation of all our principles currently. And then it adds on universal primary care, but then it continues on to mention other efforts that we've been working on over the last few years. So I feel like the intent in the beginning explains it there, but I wouldn't be opposed to having another sentence in that section to clarify it. But I do feel like the existing intent, it kind of links to it already, but.
So get rid of 5 and add the extent.
I wouldn't get rid of section 5 because we're hearing from the stakeholders that they think it would be useful to clarify who's doing what in the middle of this. We're asking them to do like 100 things right now. So at once. So I think it's good that they get together and like, who's doing what,
Who's on first?
yeah, who's doing what? And like also making sure like people aren't like being redundant is important because that's a waste of government resources.
Well, currently, it may be redundant, some of the things that they.
Yeah.
It's not true working together.
Yeah.
No one really seems to want. to.
So Leslie, for you, is section 5 is, if you look on page 1, number 19, line 19, is that not a strong enough correlation for you between those two sections, between that intent language and section 5? Since the purpose of this bill is to obtain the information necessary to develop a framework for implementation of universal primary care. Do you not see 5 as
I see universal
Yeah,
primary care
information.
mentioned in 5, but it goes way beyond it. Improving access to high quality, affordable healthcare, accomplishing healthcare transformation, state care hospital sustainability, insurance policy, that's way beyond universal primary care to me. So that's where I just saw it went beyond that. And I'm not saying this isn't good and should be done. I just see that section as sort of an outlier, I guess, from the rest of it.
All right, well, let's work with Jen and
Is it something you do to put intent language in a section within a bill instead of all at the beginning? Because it does seem to broaden the scope in the middle of it, rather than in the beginning saying, we're doing primary, and then maybe as part of that effort,
And it could be just in order to accomplish our goals of reaching universal primary care, we need blah, 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 blah. And that to me would give it context.
Is this committee discussion right now?
Yes.
Okay, then I would like to share a thought.
okay.
I just wanted to make sure that I wasn't misunderstanding that it's feeling like it, and that there wasn't another witness waiting or something. So, the section 8 situation.
Section 8 situation.
Yeah,
Oh.
the situation ship,
The
as
one
they
that I
could say.
just, the one that I just did.
Yeah, that you said you want to cut it out.
Check mark.
I feel like we don't need, like, what, the intent of that is, I think, good, but I don't think we need it. But I also feel like if we don't do anything in that regard, we're gonna get a bunch of information. It may not be all the information we need. And I'm just concerned we're not gonna move fast enough in the face of collapse or whatever you wanna call it, that's happening. And I'm trying to think of a better word that's less catastrophic, but,
Do you, can I tell you my thoughts on adding this? When I added it, it's sort of like, instead of us trying to reinvent the wheel, we should look at what maybe other states are doing so that we might be able to get ideas from them. I mean, for instance, when Dr. Song came in here and he started talking about Massachusetts is working, you know, they've had legislation around the Common Good Fund. And it's kind of the same question that you had for Nolan, which is, what have we done in the past and what's been tried? This was really just an attempt to make sure that we're not just because we haven't thought about it, maybe other states had, and we want to be exposed to that so that we can be thinking of that. That was the only reason I have this in here.
yes, I think there was good reason for that. And so what instead of just taking it out and saying, oh, we have a list now, I'm wondering if it might be unrealistic, but I'm wondering if, like, what I think would be useful would be to come back, whoever comes back, and have a little bit more information on the financing and the projections of cost and all that as soon as possible about different approaches. So, like, for example, let's say one approach is expanding the blueprint, and another approach is, I'm making these things up. So let's not get into like, oh, it can't be this or that. I'm just doing this for the sake of like just getting it out there, like expanding the blueprint, establishing a common fund, or using the taxation system. I'm just throwing it out there, like, and then we get a report like, if we go this way, here's the projected impact on healthcare spending and utilization. If we go this way, here's because it would be nice to see. And so those things could be things other states have done or Vermont has tried in the past but didn't move forward on. But like, it would be good to see numbers and have a sense of the financial impact of different pathways towards universal primary care. And if we can't afford it right now, I mean, I would disagree with that statement, because I think if we tax people fairly, we could afford a lot more right now, but we won't go there. But if in the existing boundaries on spending, it hasn't been prioritized, I just wonder if appropriations could look at all the studies and all the reports and all the things every committee's asking them to do and find a way to carve out the money needed for the actuarial analysis or whatever it would cost to get some numbers on that. Now, I just to finish the thought, we could just do that next year. And then in the second year of a biennium, make the decision, but that is now delaying implementation of any kind of universal system at least 3 years. And I just don't think I don't think that's quick enough, because there's going to be people in the next year or two losing healthcare insurance in massive amounts. And we're not going to have a safety net in place besides things like okay, so here's another example, fully funding and expanding the free clinics. That was an idea that was brought to us. Like, we could study what that would cost is a starting point, so that's another example. But I brought it up just because, like, I think we're going to see massive amounts of people with nothing soon. So I don't know, that my thought is there anything we can do now to get ahead of the curve and not, because the intent of this, I think, was good, but if we have that info, then it's like, okay, now what? What would we have done with it? Maybe we should like pick a few things and study those specific things. Thank you.
So to, for the record, I'll now to represent Gina's point, one of the things that the Shao study did was say he was tasked to come up with 3 ideas and then come up with how you fund them, right? So you have to come up with, what do you want a plan to look like? What do you want studied? It was like, do this, and then come up with your third idea, right? So if you want to do something like that, you need to put some time and thought into what it is you want studied. And then what, so it's like, I think your clock is running out, unfortunately, but like to come up with, okay, let's look at something, you need to step back and say, what is it we want to study? Like, it was very specific in the Shao. And so it took a lot of time and testimony. So I think you'd have to really be thoughtful, and you can look at the Shao study and get some ideas on an approach and framework. But it's not that easy to just say, go do a study. Like, what is it you want us to study? So that's the only caution I have. That became the framework for them with Governor Shumlin said, okay, I'm going to take parts of this plan, this plan.
Yeah.
So that was the kind of.
And unfortunately, I also want to remind everybody, we have no funds for a study.
Yeah.
So, keep going.
Yeah, so just to that point, the question would be like, how hard would it be if we had a few things that were they might be bigger than I realized when I say it. So I'll just be humble and say that to start, but like studying how to use the blueprint and the free clinics as a starting point, to providing access to care to everyone, or the FQHCs, or I don't know. I'm just wondering if there might be a way to look at the existing the things that already exist in Vermont and how to expand access to those with existing measures. I'm just wondering if
To your point, that's exactly the kind of guidance you would want to provide in Liz.
Yeah.
It's rather than just go study something, like to your point, like look at this, and this, and how does that work? So I think you're on the right track.
Yeah. And I'm just thinking that they might be able to hear, like, if we structure today in the next week, where we first hear Nolan present on the past, and then maybe Nashpe or someone comes in and in a half-hour reviews what you just found on the web. And then we look over what we know we're doing, and maybe we're like, you know what, out of all this information, we can pick something small. It could be one thing that we have them study that we decide this makes the most sense, or it might be like looking at these 3 things, combined, how might we, I don't know. It's just a thought, because the intent of Section 8, I don't want to lose that by cutting it out. I think there's something there. I don't think this was the best way I think this was noble, like the attempt, but I don't think it went far enough. And so if we're going to cut it out, I'd rather us think about like how to address the intent of it versus just letting it go, if possible. And if we have to let it go, we have to let it go.
I feel like I'm hearing from multiple people, a reworking of little b on page 1.
Exactly where I was going. I was gonna say, if I may, obtain the information necessary, including what's going on in other states.
Well, yeah, except the problem is we can't put that in the intent language if there's nowhere in the bill that says, look at other states. And I think we just heard that nobody wants to look at other states except for.
Well, no, I don't know that, no, I think we do. I think you said we do, right?
I think what we just heard from the various entities that we've been asked, that we were asking to look at other states indicated that they do not have the resources or the time to do that.
Yeah, but then you were just able, but I think Brian makes a point about having Nashby testify for half an hour or whatever. And then that gets on the record.
For this bill?
Well, if we keep it in.
Yeah, I was suggesting it as a like, it's, in other words, like section 8 had a certain intent. And what we're hearing is the resources aren't out there to do it. Plus, what I was also hearing is you can do this yourself. So what we're essentially doing is doing it ourselves. We're having Nashby come in and do section 8 for us in a half hour. And then we're like, now what? Is there something we want to put there instead? And we might be like, we can't, we have to just wait. I don't know.
If we want any movement on this bill needs to be out of this committee tomorrow. At the latest. At the latest. So we can't take more testimony. We can work on beefing up this intent. That is something that we can do, and we can keep working on making some small edits, but I'm sorry, we're out of time. We're just out of time. Karen.
Well, just along these same lines, I appreciate what you're saying, Brian, about section 8 and the intent. Like another one that in testimony for the public hearing, Dr. Governor, whatever said, we have Dr. Downs. We already have, universal access and private healthcare for certain categories. I mean, we have some in-house things we're already doing. And then Dr. Song isn't up and running yet, but his theories, it doesn't necessarily mean United States are already doing it, but there are approaches that are really being deeply thought about. And how do we get ahead of that thought process so that we have some discrete models to figure out financially how that would work? I mean, I'm just agreeing, and I don't know how to get at it in a 24-hour period, but I think that's a really important part of what I'm trying to do. Yes.
Can I get just general thoughts on whether or not people are supportive of other changes in the bill except for section 8? And or whether, we also have the option of simply just concurring with what the Senate did. We have that option. So, I want to put all the options on the table. That we can concur with the Senate and what came over, make no changes to it. We can work on going through the changes that are in this yellow marked up version that I had put forward for consideration for the committee. Or we can frankly not do anything. So I guess what is the consensus of the committee? I'm asking for people's thoughts. Lori?
I think we should move this bill.
Which one? The amended version?
Correct,
I
1.3.
think there's some really good work that this committee has done on this that would be lost if we just concurred with this.
What did you
And that
think?
but it also leaves open the possibility that then nothing happens depending on what happens in Senate, but that shouldn't concern us, right? Like we need to do what we think is best. And I think we should take out section 8.
Hate taking out section 8, however, you can't get anyone to take it.
You want to work on a summer project?
Yes.
Yes. Yes. I put this out there. This is my project. And I want to work with everybody on this. I really do. And
I think it's important. I do. I was just doing some.
So then why don't we create a legislative working group in this that works on it over the summer? So that it could be on the record instead of like people privately meeting.
If we put it in this bill, it will require an appropriation. There is nothing that says that a bunch of us can't do
I know, but it's just not,
research throughout the summer. So we
Okay.
cannot create a working group. We cannot create
Then I
a
think
summer
we should-
committee. We cannot create. We
'Cause it won't
cannot
get
create
funded.
anything that has money attached to it. So I know it's sad. I would love it. I would love to be able to create a study of, $1 million appropriation for
Mental health.
to just come back and, create the three options and that we have, but unfortunately, we don't have that. We do have ourselves. We do have ourselves. Off time is our off time.
And so this bill with some of the recommendations today from folks in the room about the separate entities, report this, with that change. I mean, I think we should do something with this.
Yeah. Okay, so let's work with Jen. We will work with Jen to beef up bottom of page 1.
And we're gonna hear back from Emily on two things, right? The section 3 and what was the other one?
The other one was section 8, but it's.
Since we're out, we're just,
Like section 3 and then, it is concerned, we don't have any resources for section 6.
Okay, let's,
I think take out section 8 and someone put a short bill up on the wall there. Make sure it gets that.
it's too late. No short forms. There will be a resources all sitting up there next
All
year.
right.
no resources for section 6, should we take that out too? Or what do you think? How should we address that?
Is there any work that the board is currently embarking on or working on that perhaps doesn't necessarily go into as detailed of a report that you did in 2017, which was a great report, by the way? Is there anything that would be able to help us coming back in January that could be accomplished without additional resources?
So looking at section 6, Emily Brown, Green Mountain Care Board, looking at section 6, we're not currently, we don't have any current reporting underway on clinician landscape or site neutral. I know there was some site neutral reporting in 585, but I don't believe we were part of that. But I can go back and check with staff and see if there's anything we're doing that interrelates with this.
Actually, let me ask you a question, Village Council. In section 6, 2, the site neutral, it does seem that somehow is a little bit disjointed from the rest of the bill. Do you know where that came from?
It was in the bill as introduced.
It was in the bill as introduced. Okay. Yes,
I'm sorry.
Jake.
Thank you, Joel Wilson, I'm the Assistant Director. On section 3, I'm guessing if you add the Green Mountain Care Board, we're likely to object. I would need to go through it more closely, but I would suggest if you're already acting on producing the clarity work, that we leave that question for that rather than making a change in the bill right now without getting real time to get it.
So the board is asking to go into section 3?
Somebody
Who asked? Oh, okay.
And I'm just saying, maybe just set that aside since it's not a request.
That's why we need section 5.
Right, which we support.
If I may, I hear you, but I'm curious to know your opinion on it. So I know you were gonna take it back, and you may say, yes, we really want to see the table. And then we could, once again, see how you guys work it out, but you may say, yeah, I agree. And I'm curious. Thank you.
Okay. So let's work on those changes and then, of course, working on the changes that you included that about flipping into here and there.
What were you just talking, that's all right,
Flipping, do you remember, Director Olson indicated that because we removed that section, put it into the blueprint report, we basically took what AHS was doing and we gave it to the blueprint. And it'll go in its own, sort of back into its own area, included in the other, within the other report back.
so back to section 6.
Section 6. I am recommending that we remove it.
That's what I
I
think.
agree.
Yeah. Okay,
6 and 8, right?
6 and 8. There, Leslie, you were concerned about all the reports.
I mean, we're 86ing 6 and 8.
Yes, you need to.
6, 7. Yeah, there. Yeah, sorry.
This may also be not possible, or any,
It's 86 anymore.
or any of these can be combined. They're very distinct, right? They just have no overlap or,
I'm sort of combining what was one into kind of another.
I'm not sure what you're referring to.
What I just explained, changed that.
You're taking section 3. Take that report, combining it with what?
It's section 2. Okay. So in section 2, go to the top of page 6. See all that struck out language in 710 primary care spending target? We had struck that out. We had taken the pieces of it and we had put in those pieces into the blueprint report. Section 3. Section 3. But to Director Olson's point, what we did was we just took something that AHS was doing and we gave it to the blueprint. So now we're gonna take the 710 section, we're not restoring it, but we're taking the language out of the blueprint and we're putting it into section, which section?
The old section 5.
Yes, there was an
issue as well, but
you also
changed the date.
There is a section 5 in the original bill, not the section 5, page 9. So on page 9, we're restoring that and incorporating that 710 struck language into it.
And in our current bill, where is it? You're storing it to where?
It's not in the current, it's struck
The
out.
idea, but the idea of it is where.
Yeah, page 9. So we're gonna section 5 that says primary care spending targets report.
Oh, yeah, so I'm looking at 1.3 and I'm just trying to orient myself. And you're looking at what?
I'm looking at 1.3 as well.
Okay,
It's on page 9 and
It's on
it's struck
page 9.
out.
It's struck out.
It's right before the existing section 5. How many reports are in this?
The old section 5 was struck.
How many does it take to screw in a light bulb?
Let's work
More.
with Ledge. I'm gonna work with Ledge Council with other people if they wish, and we will get this all straightened out.
yeah, I'm happy to.
Okay.
Yeah, we'll get to see a new
I'm sorry to
draft.
be so confused.
You see it now though, struck out?
Well, I see what struck out. I'm just trying to
It
see
will
the
make
whole.
much more sense when Jen has it configured. Thank you. Clean copy. Okay. Thank you, everybody. Oh, any other discussion? No. Okay,
I think we hit our threshold.
yes.
We're all
Thank you.
discussed out.
We are done for the day.